Georgia and I'm 6.
What's your name? This is Alice, and she's 3. And I'm Adrienne. I'm Alice and George's mum.
I'm Jake. I'm Alice and George's dad.
Just went Georgia was 3. It was the 29th of February 2012 when Georgia was diagnosed with ALL leukemia. It was a week after we just had Alice, so it was a pretty traumatic time. We were in shock, disbelief, never thought it would happen to us, but we quickly fell into a bit of a brutal treatment regime, but were, happy's not the right word, but glad that it was a very treatable cancer. So we undertook the standard treatment for 8 months, and Georgia completed the year and was in remission. And then unfortunately 5 months later we noticed that her right eye was turning in, and the leukaemia had come back and she had relapsed. So her chances of survival were now a lot tougher. We went through basically for, I can't remember how long it was in hospital. 140 days in hospital, doing intensive chemo, which made the first round pretty much look like a walk in the park. And her best chance of survival was a bone marrow transplant, which meant that she had to be... Oh, me? No. Which basically meant that the chemo and radiation completely killed her existing bone marrow, and she was rescued by a donor's stem cells, which happened to be a newborn baby. And we're 2 years post-transplant, which is a very, very big milestone. She's not deemed cured yet, but we're on the road to recovery. She had a chest infection and she had gastro, which we both thought was normal. She was going to kindy. The only thing was she was extraordinarily pale and had high fevers that we just couldn't get rid of, basically. So for peace of mind, we took her to our local GP. Pretty much within 15 minutes, she was concerned of her colour. Her liver and spleen were enlarged, and she advised us to go to the Children's Hospital for blood samples straight away. And I remember her saying she didn't want to concern us, but it was her job as our GP to let us know that on one end of the spectrum it could just be an infection, but at the other end it could be lymphoma or leukemia. So we went straight to the hospital, got bloods done, and within an hour we were told that she had cancer.
It's pretty remarkable from our GP's perspective that they diagnose it straight away. Like,
it doesn't,
through hospital you hear stories for weeks and weeks before they finally go to the cancer test. It's always a virus, it's always this and that, so we're quite pleased with our GP after that. What do you do? I mean, it's just it's like a wall of noise or something.
I remember.
And what? What do you remember?
I was always vomiting in the middle of the night.
Yep.
Mm-hmm. And it wasn't very nice, and I did not like it.
No.
Because I had to be waken up by my sleep.
Mm-hmm. Yep.
And it didn't.
This is why you were having the medicine, yeah?
Lots of yucky medicine.
And it didn't look nice.
No.
No.
But the nurses were nice, weren't they?
I know.
Doctors were good.
Yeah.
But it's pretty much your worst nightmare.
Yeah, and my what?
Treatment is pretty brutal and savage.
I know. I had to get the biggest needle that I've ever had, a fly needle.
In the thigh, that's right.
Ow.
Awesome. Keep sitting. Change position.
So there's a standard treatment that you go through, which at the time you go through it, it seems pretty heavy, and it is pretty heavy. And then after it's a 6-month protocol, but it's always delayed because of issues that arise. And then, I think ours took 8 months, and then you go on to what's called the maintenance phase, which is just low doses of chemotherapy. And that's an 18-month period. And Georgia relapsed about 5 months into that maintenance period, which
was very quick.
It's very quick.
A quick relapse, which meant it was quite obviously a very aggressive cancer.
And
that they didn't pick up.
She's still under treatment at that point. So it's basically a bad sign, a very bad sign. So
Nothing happened?
Then the new treatment regime to try and rein it back in makes the first treatment regime look like a walk in the park. And so...
Keep sitting, please, Georgie.
We basically ended up doing, the first time round we were in hospital maybe 10-15% of the time, but we were basically in hospital for 7 months continuously. And then 100 days of isolation in the post-bone marrow transplant. The issues around it, if you want me to go into them, are horrendous. So we had situations where she was getting a situation called bradycardia, which her heart rate was dropping to basically 46 while she was sleeping. And for paediatric patients, they're supposed to start CPR at 50, and it's a code in the hospital. But her blood pressure and her perfusion was all fine. So the doctors didn't really know how to deal with that because the book says it's a code. So intensive care needs to rush up, ventilators, the whole bit. But she was easily rousable. Her heart rate would come straight back up. So, and that went on for probably, there was a 3-week period of that.
But on top of that, every day, pretty much every hour, there was some side effect from the treatment that we had to deal with, whether it was ulcers, inflamed bowel, liver problems, not being able to go to the toilet, pain, potential surgery, internal lines being infected. It was relentless. Yeah, and it was from the treatment, not the cancer.
We had surgeons coming through to see if her bowels were about to rupture because they were so inflamed, and to see whether they needed to do emergency colonoscopies and things like that, which is pretty hectic. They didn't, thankfully. I think we're about that close from that situation. Because the trouble with the existing treatment, while everyone lauds the success rates currently, and the success rates are very good, when you look at the origins of it, the current treatment originates from the use of nerve gas in World War II. So methotrexate is a derivative of mustard gas, and they found out that it's a poison that selectively affects fast replicating cells. So you lose your hair because they're fast replicating. You lose all the mucus in your mouth and through your throat and in your stomach. So you ulcer up, basically from top to bottom, and hopefully you lose your cancer. But the doctor's job in that situation, particularly in a relapse situation where it's presumed to be exceptionally aggressive, is essentially to push that poison as hard as they can to but not push it so far that the poison kills the patient. And that's the balancing act, which in practical terms the oncologists are playing. And so they put it in there, and then their whole job, it's quite a recipe, it's a prescriptive way that they put it in, but then their whole job beyond that is recovery from that poisoning. And that's where the complexity for them, the doctors, comes in, because there's just so many issues which can arise as a consequence of that.
And that all happened before the actual transplant. So basically what that second round of treatment did was kill her existing bone marrow without hopefully killing Georgia, and then get full body radiation from top to toe because it was in her blood, so they had to do her whole body. And then she was rescued by stem cells, which in this case were donor stem cells from a newborn's cord blood. And then that propagated, and it went from there. We were very lucky that it was a good match. There was lots of it, and it took, and she just
So the global,
Do something silly.
the global,
Very soon, okay?
so the global treatment-related fatality rate around having bone marrow transplants 20%, just from the treatment. That's not whether it works or not. That's the treatment has taken them out because it's so harsh. So getting told that, there's a whole bunch of emotional issues around it. The kids are wrecked. They're not sleeping. They're up and down all night. There's continual blood transfusions. Because their blood's not functioning properly, so you've got to top it up. You've got to force medications on them. You've got to get them to do things that they, frankly, as a 5-year-old, they don't know why they're doing it, and they just don't want to do it.
But they do it.
And you've got to force it. And it feels that's probably one of the most difficult bits, apart from dealing with the sickness, is that there's this whole, you almost feel like there's a betrayal of trust there, because they're saying, don't let them do it, Daddy, don't let them do it, Mummy, but they're literally having to be held down, given needles, given medicines, screaming at the top of their lungs, invasive procedures, so on and so forth.
Yeah.
MRIs at 11 o'clock at night, all of this sort of stuff. So
But they do
the whole
it.
thing snowballs on itself. And
Snowball.
yeah,
Snowball.
but it's not a fun cold snowball. And it just becomes chaotic. Like, it's because you're just putting them in this really precarious life position as a result of the treatment. So if you want a reason why you need to improve the treatment, is because yes, the treatment's working, but it is a pretty rubbish way to fix the problem at the moment.
You're basically poisoning your
Yeah.
child.
Yeah, and hoping it works.
Yeah.
And it's genuinely hoping it works, like, because they can't say, if we do this,
That's
it
right.
will
There
work.
are absolutely no guarantees.
So the stem cells treatment is obviously quite new. And that's a result of medical research.
Yeah.
Absolutely.
Yeah.
Yeah, I guess we're
Yeah.
quite grateful for that.
So
I can't begin to tell you how grateful we are.
the whole leukaemia program is a continually evolving clinical trial. So 30 years ago, the survival rates were almost zero. Then they got it up to 50% with the introduction of steroids, and then incrementally it's kept on going. And right now they're on study 9. So there's 9 5-year iterations of the trial where all of the data's collected. A global panel looks at that data, and then for the next trial they say, well, let's make incremental changes and we'll put half of the patients on this and half of the patients will get the old way. And then we'll compare the data on the new way versus the old way. If the data's better, we adopt the new way. And then we go into a new phase for another 5 years. How do we then... And so the whole process it's not just about finding revolutionary new sort of magic bullets for everything. The whole process is in itself a refinement and a trial and an experiment that is just continual. And so none of that stuff's funded by government currently. So we gave a donation to the hospital and it funded this program manager's salary for the Australian clinical trial into leukaemia for a year. Because that stuff is just not part of the package. The government very generously, I mean, our healthcare system's terrific here, and the government very generously, beds our children, provides the consumables, pays the nurses who are awesome, and provides all those fundamentals. But the ongoing data collection, experimentation, all of that stuff is funded right now by the generosity of the public and medical research grants.
So I guess that's where the Medical Research Future Fund would come into play. I guess you'd be hoping that some of that money would go towards leukaemia research.
Yep,
Yeah,
exactly.
and towards, there's wonderful things happening. The Children's Cancer Institute are adopting a program which they're calling personalised medicine, which totally makes sense. It's looking at a child, in this instance, biology and genetics, because everybody deals with the sickness differently. So why would they deal with a child's cancer differently, which will be able to then allow them to tailor treatment specifically to a child's genetics and biology. So somebody like Georgie might not have relapsed and had to go through that second year of torture. Generally, it pretty much stops your life.
Yeah.
And every day is a worry.
Yeah.
And it's beyond stressful. And it's just it's difficult to put into words how hard it is. But there, you still, sometimes you find some light and you do carry on, and you do it for yourself and especially for your children. And we had a lot of community support, which was amazing, from friends and family and just the wider community, and the Sydney Children's Hospital were fantastic. So, and it sounds awful, but it kind of becomes your new life and part of your new routine, and you somehow adapt, and you have your good days and your bad days, and you're terrified, and so huge impact.
Yeah, I think the divorce rates, we're not divorced yet, but the divorce rates run up at around plus 80% for these situations, because people just get so stressed. And also after the fact, like, I know my head's not right, frankly.
We're 2 years post-transplant, and we're still obviously dealing with what the hell happened and what we've been through, and trying to process and how to not be terrified every day, wondering if it's back.
Every cold, every temperature,
fever.
every fever, you are petrified.
Yeah.
So, and we try not to let it, but then in some ways that reflects back on Georgia, because we start searching for, what's wrong, rather than I'm just a bit tired or I've had a big day. We start looking for the big issue,
Yeah.
So, and it's difficult to manage from that perspective.
Yeah.
So psychologically, it's pretty difficult.
Yeah.
And I guess you often hear these days, childhood leukemia, it's a good cancer
to get
if you're going to get a cancer.
Yeah. No, that's what we were
Yeah, well,
told. That's
is.
what we were told as well, and it still is,
Yeah.
because it's treatable.
Yeah, it's not good to get twice. It's very not good, but the first time round you're probably sitting okay. And frankly,
And they take comfort in that fact, absolutely.
And frankly, we're on the wards with kids with a lot rarer and more difficult
Tumours
things to treat.
Yeah.
And tumours. I wouldn't have swapped places with them for anything, because they're getting chemo directly into the brain. They've
Getting radiation every day, twice a day for nearly 6 weeks.
Yeah.
So,
Which requires a general anaesthetic. So it's 2 general
These-
anaesthetics a day for 6 weeks continuously.
Yeah.
So the toll that takes on their bodies,
It's very, very ugly.
and the impact of the radiation, that level of radiation on their cognitive development, so yay, we got it. Geez, it didn't come without cost.
Yeah, that's exactly it. It's like,
Yeah.
I think people think they hear the success rates, but they don't necessarily know the
Yeah.
treatments involved to get
Yeah.
it.
Yeah. Oh, that's right. And I mean, yeah. I mean, your friends and all that do their own research and do come back and say, oh, well, it's leukemia. I hear there's great success rates, and oh, you know, she'll lose her hair and all that kind of stuff. But that's okay. Once you're in it, you're just like, mate, the hair's the least of your worries. And
So a massive part of the problem on this, with this, particularly paediatric cancers and leukemias and that is, kids don't get cancer very often. And so the primary driver of clinical trials is commercial viability. And that's just the old market economics, right? If there's a big attractive market where I can get a lot of revenue, I'm going to spend a lot of time trying to crack that market. With kids, there's not enough customers, if you like. So there's no commercial research being done in the area for kids. And the difficulty then compounds because kids are different to adults. They haven't been through puberty. We've got a bunch of stuff in our genes which is switched off. They've got a bunch of stuff in their genes which has yet to switch on. So if we start using genetic therapies, we don't know what we're having, what knock-on effects we're having. And so we can't just take a genetic therapy out of adults and plug it into kids. And it's all about genetic therapies at the moment. So again, where these medical research funds become so important is because society is, because it's commercially oriented, is essentially failing to protect the most vulnerable, which is our kids. Because there's not enough commercial imperative for big pharma and companies to pursue these objectives. And so it requires the interposition of either some sort of legislative framework to force the companies into doing that, which is probably not ideal, or it requires a massive medical research fund which can then fund that research, because the task is huge. And while the numbers of lives is lower, the number of years of life saved and the like for like, you probably want to save a future contributor of society more than you want to save someone who has contributed, if you like. Sorry to the people, the elderly and co. I mean, obviously, it's not that stark, the contrast, but kids are worth saving, frankly. And they haven't had the experience and the ability to contribute. And maybe some of these kids who could have been saved if more work had done would have come up with some breakthrough science or some masterpiece of art or something, but all of that potential is lost and gone because we didn't save their lives.